Hello everyone, welcome to the ISPRM International Rehabilitation Week. My name is Alessandro Desire. I'm Associate Professor of Physical and Rehabilitative Medicine at the University Magna Grecia of Catanzaro and Vice Chair of the ISPRM World Health Forum. Please, Professor Goodman.
Hello, good morning good morning in America, good afternoon in Europe. So my name is Juan Manuel Guzman Gonzalez. I am Honorary Lifetime President of the Mexican Society of Physical Medicine and Rehabilitation. I am academic of the Mexican Academy of Surgery. Also, I am the Treasurer of the Board of Governors. I am also academic of the American Academy of Physical Medicine and Rehabilitation, postgraduate in Pain and Leadership, President of the ISPRM World Congress in Cancun, Mexico in 1984, past President of Latin American Medical Association and Congress and Latin American Medical Association, AMBLAR, and board of the international member of the American Journal of Physical Medicine and Rehabilitation.
Hello, my name is Ignacio de Besa. I'm academic coordinator of physical medicine and rehabilitation at the Mexico National University. So I am editor of the Mexican Physical Medicine and Rehabilitation Journal. Good morning, everyone from Mexico.
So we will be the moderators for today, and we will support it by the ISPRM office as host Jessica Idi and Nicole Carducci, and we all thank them. Please, Professor Guzman, you could introduce the first speaker.
Of course, yes. Let me check here. Okay. Just 1 minute. Okay. Okay. Let's see here. Okay, let's see. Okay, it is my pleasure to introduce the first speaker in this. Is Professor Farid Khan and Dr. Abadia, and also I introduced Dr. Colin O'Connell, and they will start speaking about disaster. My very close friend, Gary Khan, Farid Khan, please start and welcome. Farid Khan is start here.
Sorry, just a correction. We are starting with the video from Cochrane, the interview with Cochrane.
Ah, okay, sorry. It's because I was interviewing to the second part. Yes, wait.
Welcome everyone to the second edition of ISPRM International Rehabilitation Week 2021. My name is Aaron Yang. I am a physician at Vanderbilt University Medical Center in Nashville, Tennessee, and I am a member of the organizing committee. And so in today's session, we will focus on perspectives of institutions worldwide working in the field of rehabilitation medicine for healthy aging. And we'll have interviews with representatives from Cochrane, Humanity and Inclusion, and the International Society for Prosthetics and Orthotics. And so I hope you'll enjoy these sessions and ask questions to our speakers via the Q&A section. And please be sure to write down where you are from. Look forward to seeing you.
And so let's start our first session today with rehabilitation, healthy aging, and the role of evidence, an interview between Professor Stefano Negrini and Professor Tracy Howe from Cochrane Rehabilitation. Professor Negrini is a full professor in physical and rehabilitative medicine at the University of Milan in Italy. He is also the director of Cochrane Rehabilitation and co-chair of the Cochrane Council. Professor Ho is the director of the Cochrane Campbell Global Aging Partnership and is based in Glasgow, UK. She was elected as governing board member in July 2017, served as treasurer from October 2018 to March 2019, and is a member of the board's governance and finance audit and investment committees. Let's watch their interview on rehabilitation, healthy aging, and the role of evidence.
Hello, everybody. I'm Stefano Negrini, and I have the pleasure today of substituting our incoming president, Francesca Gimigliano, that unfortunately is not able to participate to the meeting. I can introduce to you to Professor Tracy Howe, and we will discuss a little bit about Cochrane, about healthy aging, the decade of healthy aging. So, Professor Howe, welcome, and tell us a couple of words about what is Cochrane.
So, Cochrane is an international network. We're a not-for-profit organisation, so we're a charity, and we are engaged in producing high-quality evidence that enables better decision-making in health and care, we were well known for this. We've been around for 3 decades, basically we produce lots of high quality evidence through things called systematic reviews, which collate information from individual trials and use statistical analyses to provide the combined data, which enables us to have more confidence in the results.
And who are the persons behind Cochrane, and also who are the person you are working for?
Okay, so Cochrane is for anyone who's interested in using high quality information to make health decisions. So that includes clinicians, patients, carers, researchers, policymakers. And Cochrane evidence is really a powerful tool that enables people to make better decisions. Our members and supporters come from more than 220 countries worldwide. And we are really a global independent network, and we have over 100,000 members and supporters.
And what does the word independency means to Cochrane? I know it means a lot, but what
Yes.
do you mean with that?
So Cochrane is an independent organisation, and we pride ourselves on our independence. So we don't accept any commercial funding or any conflicted funding. And our authors and editors and people involved in Cochrane have to declare any potential conflicts of interest from a commercial sense. And that really enables us to be seen as an independent source of reliable, high quality information that doesn't have any commercial or financial interests.
Okay. And so in Cochrane now, we have since 5 years Cochrane Rehabilitation, and Cochrane Rehabilitation is a field in terms of in Cochrane's term, there are 4 types of groups. One are the review groups, those who produce the Cochrane library, in fact, and the contents of the Cochrane library. We have method groups that develop new methodology around systematic reviews. We have geographical group that work into the single country to make evidence important into the country with a function that we call knowledge translation. That means conveying the information to the people to allow people to achieve better health. And then there are the fields like Cochrane Rehabilitation, and a field is a real bridge between the community or working on that specific field and Cochrane, with the aim of, on one side, disseminate the evidence produced by Cochrane to the rest of the world. On the other side, to allow Cochrane producing the most important evidence for the field. That means prioritization, so deciding what is important for your own field, and the problem, specifically for rehabilitation, the problem of evidence gathering that are important to be conveyed to Cochrane to allow Cochrane to produce evidence more meaningful. And together with the field of Cochrane rehabilitation, there is the field of which is responsible Dr. Howe, is the Cochrane-Campbell Global Aging Partnership. Quite long, but means a lot. So tell us, please.
So we talked about Cochrane. Cochrane is around looking at health and care decisions, and the Campbell collaboration looks at sort of more the social aspect of evidence, looks at things like education and economics and various other things. Now, aging, as you know, covers more than just health and care. So we are working in partnership with the Campbell collaboration, so hence the Cochrane-Campbell Global Aging Partnership, to look at producing evidence that meets the needs of an aging population. So it's not just a medical model, it includes other aspects such as societal issues, equity, health systems, etc. So both organisations have been around for over 3 decades, producing trusted evidence to inform decisions. And basically, we are playing a role in strengthening the data, research and innovation, and generating impact for older people's health and well-being.
Yeah, in fact, about that, there is this decade of the healthy aging, and this is one of the main reasons why you are here with us today. And can you just tell us what it is and how the world of rehabilitation could contribute to this decade?
Yes, exactly. So we know that the populations around the world are aging very quickly. And already there are more than 1 billion people worldwide who are aged over 60. And a lot of those people are living in low and middle income countries where health and care decisions are needed. So the United Nations, as part of the Sustainable Development Goals, have aligned to bring together governments, civil society, international agencies, professionals, academia, the media, to look at improving the lives of older people and their families and their communities in which they live. And so this is really about moving things on at a global perspective. The decade is going to address 4 areas for action: age-friendly environments, so that includes communities, cities, individual dwellings, and ageism, because we know that that has a major impact in many things, including provision for health and care, integrated care, and long-term care. So there are many areas there in which rehabilitation can have an impact, particularly in the 3 areas there in terms of the environment. So we could look at aids and adaptations, integrated care and long-term care, obviously key areas in terms of rehabilitation.
In fact, as Cochrane Rehabilitation, we are also trying to give our contribution to the decade. And just to give an example, we have recently been involved in an effort by Cochrane on possibly being part with WHO of the production of the new low back pain guidelines that will focus specifically on the elderly. And as Cochrane Rehabilitation, we have been asked directly by WHO to work on the assistive devices, including lumbar support, but not only, and low back pain. That is a specific area that has to do with aging. And then, obviously, we know very well how much the importance of evidence of rehabilitation increased due to the aging of the population. That is strictly linked to an increase of disability worldwide, and that is part of our everyday job. So how, in fact, is the
partnership,
Cochrane-Campbell Global Aging Partnership, how does it work?
Yep. So we've been working for 6 years with the World Health Organization aging team to produce high quality information and evidence to inform healthy aging. We've been part of members of the International Consortium on Evidence and Metrics for Healthy Aging, and in that role we contributed quite significantly to the baseline report for the decade. I did forget to mention the decade is 2021 to 2030, so we're right at the beginning of the decade. We've also published open access special edition of the Cochrane Library app, which brought together all of the evidence, the Cochrane evidence that was included in the baseline report for healthy aging decade. And that's open access and freely available. It's called A Focus on Healthy Aging. So if you're interested in looking at that, you can find that on the cochrane.org website and go to the Cochrane Library and then look at the special edition there. We've made further contributions to the decade. We were invited by the World Health Organization to produce an evidence and gap map, which is published on the Campbell Library, and that's around mapping evidence to disease burden, looking at functional ability, which is obviously one of the decade's priority action areas. Other things that we are able to do is look at highlighting the fact that older people aren't a homogeneous group. So we look at healthy aging really from an equity lens. We know that many randomized controlled trials limit age within their trials, often have a cutoff age, 60, 65 for studies. We are arguing that that's not necessarily a good thing. We need to focus on an aging population, and the other thing is around people with comorbidities. As we age, we pick up more and more different conditions, and often those people are excluded from clinical trials. So we are trying to highlight the need to have people engaged in clinical trials as participants that actually reflect the public to which we serve in terms of the evidence. Otherwise, the evidence is missing key elements within it. So there's some of the things that we're doing there. We are also trying to look at core outcome sets for healthy aging to reflect the fact that when we are generating evidence, we have comparable data. But in doing so, we need to make sure that we are measuring the things that older people that matter to them, so that these real differences in things that we measure are meaningful, and they're not just clinical outcomes. They're actually meaningful outcomes to older people, their family, carers, and communities. Other things that we are engaged in is getting evidence out to the general public. So we have a Wikipedia project, and we're putting Cochrane and Campbell evidence into Wikipedia, so that anyone who does a Wikipedia search will have access to the high quality information that Cochrane and Campbell produce. We've edited over 500 Wikipedia articles now, and we've had almost 30 million views on those articles. So it's a good example of making sure that we get evidence, high quality evidence, to the right people at the right time when they need it. And obviously, if we look at how evidence is accessible globally, China doesn't have access to Wikipedia, so we're developing a healthy aging evidence WeChat project for audiences in China. So they're just some examples of what we've been doing.
Yeah, on one side, I could comment that the issues you are facing methodologically are exactly the same issues as in rehab, because in rehab we have to deal with comorbidities. In rehab, we have to deal with some specific populations that are usually excluded from randomized controlled trials. And we could probably start a discussion about these issues, and if the model of randomized controlled trials is exactly the right model to face these issues, and what Cochrane should do in this direction to have meaningful evidence also for the people that don't enter in randomized controlled trials. So that is a topic probably for future discussion more than, or if you want to say something about this, that could be.
Well, Cochrane is a key player in methodological development. Cochrane really took the notion of systematic reviews and meta-analysis and developed that for the needs of healthcare decision making. There are a number of different areas in which Cochrane has developed methodology. One of those is in prognostic trials and prognostic reviews, network meta-analyses, where we're looking at lots of different areas and pulling those together. In other areas are the
complex interventions,
diagnostic test accuracy. So there is potential scope to develop a methodology that's more specific to rehabilitation studies. So I know, Stefano, that Cochrane Rehab is involved in that area and pushing to promote methodological development there. And I think that that's an excellent contribution from the rehabilitation community.
Yeah, and this is one of the field in which we are trying to work, and having a methods group there would be great. But we will discuss that in the future. And yeah, you raised the issues of accessibility of Cochrane evidence is highly relevant, and there is this notion of open access coming out. And so tell us something about that.
Okay, so the open access and open science movement is a global initiative to get information that has been any research evidence that has been funded, particularly that that's been funded through public funds, accessible to the world free of charge at point of access. That's a complete change from other things. So Cochrane is committed to open access. We produce plain language summaries to help people understand and interpret research findings. They're all freely available. 70% of our library currently is open access, and we're moving to full open access in 2025.
Yeah, there is this also importance of not really being English language centered. And this is something that Cochrane is taking very seriously lately. And there is the translation already in 6 languages of many Cochrane reviews. And we have to be well aware that only 6% of the population are native English speaking, and 75% don't speak English at all. So really that is something that should be overcome. So we have translation into over 15 languages. We have plain languages summaries translated in much more than those languages. So really Cochrane is moving toward the other languages as much as possible. And all of you can be involved in the Cochrane activities, specifically in Cochrane Rehabilitation. Remember that on the 16th of December, we will have our 5th anniversary. So we will have on the 13 and 14, 2 moments with interviews like this one, with 4 people discussing about specific problems that have been faced by Cochrane Rehabilitation in these 5 years. That it will be the 13th and 14th, and you can stay tuned on our website to see the dates and the time exactly. And the 16th, we will have a meeting with everyone who is interested in contribute to the growth of rehabilitation into Cochrane. And also, obviously, you can all become Cochrane Reviews authors. Obviously, you need quite some training. It's not that easy. Cochrane Reviews are really challenging. When you produce a systematic review outside of Cochrane, probably takes 6 to 9 months. When you are into Cochrane, it takes much more because you have the best methodologies challenging you and requiring you to do the best. But that is a really incredible training moment. Yeah, I would like to close with one, let's say, a little bit tricky question. because Tracy Howe is a physiotherapist in origin, and she is the co-chair of the governing board of Cochrane, the most important board into Cochrane. And I am the co-chair of the council, that is the representative of all the community of Cochrane. So out of 6-7 people, 2 of them are coming from rehabilitation. What do you think about it?
Well, I think it's really important because rehabilitation covers so many aspects of health and care. It doesn't just cover one speciality in terms of you know, a defined group. It cuts right across the whole of health and care. And I think that that's really important to have that aspect. And it's not surprising that people who work in rehab are able to work across all of those areas. And it's fantastic that we're representing rehabilitation in its broadest sense in very senior positions within the Cochrane collaboration.
And that tells a lot about the work we have done in all these years as community to increase the evidence in the world of rehabilitation. And it's not true anymore that there is no evidence in rehabilitation. There is a lot of evidence, but should be improved as usual. And so we have to work about that. But rehabilitation has its own evidence and is represented into Cochrane. That's great. So I think we can close here. Thank you very much, Tracy.
Thank you.
And we'll leave you to the question and answer session. Bye-bye.
Bye.
Okay. Okay.
Professor Negrini, I would like to mention are available on the handout section. You can find in the chat, and you can download any additional files. Please feel free to use the questions feature if you want to ask the speakers or if you need any assistance. All the session will be recorded and you will be notified once the material is available for your access. We will now begin for questions and answer session, and you are invited to write the question in the question section. If there are not, somebody has some questions? Dr. Alexander?
Are there any questions?
I have a question.
Please, Professor Guido.
It's first of all, congratulations for Professor Tracy Howe and for Stefano Negrini. Both of them are you terrific lectures. My question is, what are your proposals to improve scientific evidence in rehabilitation programs for healthy elderly people?
Should I take that? There are many areas in terms of rehabilitation for the aging population. I guess what you're referring to is about the healthy aging process, and that's very much focused on preventative measures, public health measures. So, for example, there are a number of Cochrane reviews in public health looking at physical activity and exercise. So the Cochrane evidence around that that will help inform those sort of broader policy decisions and public health measures. In addition to that, there are specific programs. So, for example, falls prevention. There are a number of Cochrane reviews in those areas, which not just look at people who've already fallen, but also in terms of preventing injurious falls in a healthy aging population. And in addition to that, there are other areas such as appliances and adaptations in homes. And again, these are to, effectively prevent people developing injuries, which are a key area, because we know that the cost of falls and injuries are very high, both from an economic perspective, in terms of tying up healthcare resources, but mainly in terms of the societal cost of those for individual people, their families, carers and communities. So, in terms of prevention of issues that in terms of physical activity, that there's much evidence already out there, and there are many Cochrane reviews that relate to those. I hope that answers your question.
Thank you, Dr. Ho. I would like to do another question for you and Professor Negrini. What about the role of telerehabilitation in healthy aging, in particular after COVID-19 pandemic? Because we know that with this pandemic, there are a lot of healthy aging that are isolated, that are at home. How can we do with them, and telerehabilitation might be an appropriate therapeutical option?
Perhaps I can pick up that. We just submitted a qualitative Cochrane review that perhaps people are not aware that is possible to have qualitative systematic reviews. And we have done one about the problems in implementation of telemedicine, and with our colleagues from Colombia, Luz Elena Lugo and her group was the main author of that Cochrane review, and there are very interesting insights about the interest specifically in the transition phase between the hospital and the outpatient, and the interest of patients in receiving telemedicine specifically in that phase. But I see telemedicine mostly as a different way to convey the same services, so I don't see it as a specific rehabilitation intervention. So it's a method more than an intervention, and can be applied in many different situations.
Perfect. Thank you for the answer. Are there any other questions?
May I just remind people that if they wish to access any information about Cochrane, the website is cochrane.org. You'll be able to find all of the information there. And if you're interested in becoming a member or a supporter of Cochrane, you can access that there. And also you can access the Cochrane library through that website. So cochrane.org is the place to go for any information about Cochrane.
And I can add rehabilitation.cochrane.org as all the evidence relevant to rehabilitation, as well as the evidence relevant to COVID-19 and rehabilitation. So that is also a place where you can find specific information.
Are there any other questions? Probably from Professor Ignacio De Vesa. Please switch on the microphone. I think that the microphone of Professor De Vesa is closed.
Okay, I think, yes, I have a question for you. What can you recommend for the developing countries in order to start the publication of rehabilitation articles relating to evidence?
Perhaps I can say something about it. We struggle to expand as much as possible what we are able to find in terms of evidence to include low middle income countries. Just to give you an example, on the 16th of December, we will have our 5th anniversary. You can find in our website all the information about it. And one of the sessions will be devoted to low and middle income countries. So if you are really interested in contributing to the work of Cochrane Rehabilitation in collecting evidence there, you can participate the 16th of September at 5 p.m. Central European time. But you find all the information in our website. There will be other 2 sessions. It is our 5th anniversary, so it's very important. The 13th and the 14th of December will have divulgation sessions, while the 16th will be to build up the next 5 years of work in Cochrane rehabilitation.
Thank you very much.
Perfect. Thanks, Professor Negrini. Thanks, Professor Ho. And so moving on to the next session. Please, Professor Guzman, could you introduce the next session? You should switch on the microphone.
Okay, thank you very much. Let's move to the next session, which is related with humanity and inclusion. In this session, the leadership of ISPRM Disaster Rehabilitation Community, led by my very, very close friend Farid Khan and Dr. Amaya, interview with Eric Weirs from Humanity and Inclusion and Dr. Colin O'Connell from Team Canada Healing Hands about the experience related to the rehabilitation program with Healthy Aging. It will be part of this team. Farid Khan, as I told you before, very close friend of mine. She is director of the rehabilitation services at the Royal Melbourne Hospital, director of Australian Rehabilitation Research Centre, clinical professor, Department of Medicine at the University of Melbourne and the Nosal Institute of Global Health at Monash University. Bhaskar Amadya, she is a PhD, big project manager, Department of Rehabilitation Medicine and Australian Rehabilitation Research Centre. Colin O'Connell, she is working at Division of Physical Medical Rehabilitation at the University of New Brunswick, Canada. And Eric Weirs, physiotherapist, rehabilitation specialist, emergencies and preparedness at the Humanity Inclusion Belgium, from Belgium. Shall you start there, Farid?
Good morning, everyone, and thank you for joining us for the Rehabilitation Week for 2021, organized by the ISPRM. My name is Sari Khan, and I'm a rehabilitation physician in Melbourne, and I'm joined today by my colleague, also from Melbourne, Dr. Bhaskar Amadya, and our 2 fantastic guests, Mr. Eric Weirs, who is a rehabilitation specialist for humanity and inclusion and technical manager, and his area is huge from Afghanistan right through to Brussels in Belgium. Very impressive. And of course, we have Dr. Colin O'Connell, who is a rehabilitation physician at the Stan Cassidy Centre for Rehabilitation and also the University of New Brunswick in Canada. And we're delighted to have both of you join us today for a very brief 20-minute discussion on healthy aging and how it impacts on people with disability. Before we start, I just want to sort of give the background for some of our audience. So healthy aging and aging with disability, this is the decade of healthy aging. So it's incredibly important for our organization, the ISPRM, and for all our colleagues, doctors and allied health across the world to have a better understanding of where we're heading with this and what our contribution can be from the perspective of the ISPRM, working with our many NGO and INGO collaborators and partners. Now, we know that life expectancy globally is on the rise. And I think by the figures indicate by 2050, there will be almost 1 in 5 person who's considered aged. However, healthy aging and life expectancy are not uniform across the countries. So for instance, some of the data that we have seen shows that by where are we? Here we are. But the healthy aging in older age, there's a difference of 30 years at birth and 11 years for life expectancy at 60 years between different countries. So that's phenomenal. And then we look at the number of disabled people in the world, and the conservative measure is over 1 billion. And we also know that access to health services is not uniform across the developed and the developing countries. So it's really important. On the other hand, we know that we have better medical care, medical and surgical care. We also have better rehabilitation services somewhat compared to the previous decades. And we also know technology is on the rise, and we've had to alter the way we deliver services across the globe because of COVID, the pandemic, and many other challenges around the world. So I thought that this would be a really good forum to have a discussion with both Eric and Colleen. So we just want to hear the experiences and how we can enrich our own learning by listening and learning from them. So we have a couple of questions, and we're going to take turns. So the first question, and I hope Eric, you can go first, or Colleen. Please tell us about your humanity and inclusion organization. Eric?
Yeah, well, Humanity and Inclusion is an international NGO. It is based in France. It was created almost 30 years ago in Southeast Asia. And its main aim is to support, to improve the lives of people with disabilities. We mainly work in regions that suffer from underdevelopment, in low and middle income countries, but more recently and unfortunately in the conflict settings all over the world, where we know that vulnerabilities and more particularly people with disabilities have huge challenges to overcome. So our focus is then on working with rehabilitation services that have to be improved, but also other, let's say, other means such as psychosocial support, inclusion. We have a whole range of services that we promote then with either the local institutions or with caregivers or with the persons that are surrounding the lives of the people with disabilities to improve their lives.
Excellent. And you were saying earlier that you're in Afghanistan and you almost have over 200 staff working with you there.
Yes, actually, we have been seeing challenging times this year, and our 260 staff, they have still been continuing to work despite these very difficult conditions, where we work on also supporting internally displaced people in Afghanistan with mobile teams that provide rehabilitation services. We also provide prevention and education not to step on landmines or unexploded devices. And of course, we give also psychosocial support to the communities that are affected by displacement and all the different situations that occur in Afghanistan. And alongside this, we do also support the physiotherapy profession by training the young physiotherapists here in Afghanistan, male and female. We focus a lot on having a very gender-based education so that also the services are available for both genders equally.
Thank you. And that is so needed in the current day, isn't it? Thank you, Eric. Colleen works with Helping Hands Canada. So we're really interested also in hearing Colleen's perspective.
Thanks, Fari. And actually, the organization that I've founded and work with a large number of volunteers is called Team Canada Healing Hands. And we're actually celebrating 20 years this year. Our focus has been on capacity building in rehabilitation and working only with local organizations. So we're a very small organization, but we go into areas at an invitation of a grassroots or local organization. Often it could be a clinic, it could be an outpatient program or a community-based rehabilitation program. And we'll provide volunteer mentoring and side-by-side capacity building in the country to help build the rehabilitation capacity in areas that are less serviced, so areas of low resource. And part of that has been a lot of community-based rehabilitation. And in the face of some disasters, we've worked hand in hand with larger organizations such as Humanity and Inclusion, particularly in countries like Haiti and Nepal with their recent disasters.
Thank you for highlighting the great work you're doing. Can you highlight the HI and Helping Hands Canada initiative on rehabilitation inclusive health system?
So again, it's Team Canada Healing Hands, and part of what we do is in terms of trying to, I mean, inclusivity is a huge challenge, and I think that's why an organization like the one that Eric works with, having it as the name of their organization is so important. In many of the lower resource countries that we work, persons with disability are often very much excluded from society. And even within that group of persons with disability, they are the most marginalized group. And when you're a senior or an elderly person, you are even that much more marginalized, particularly because of those social determinants of health, of accessibility and poverty. And so we really focus on trying to work with grassroots community organizations and working with often lay community members that can include persons with disability and include persons who are of older age, involving them in
Hola, hola, todo muy
identifying
bien,
where
¿eh?
their
Felicidades.
priorities are, where their needs are,
¿Sí?
and being responsive to those.
¿Alguna recomendación
Really
para mí?
trying to avoid that top-down approach where it's like, let me tell you what you need, as opposed to where are your issues and your concerns, help me understand, and how can we come to solutions together and support you in a way that is going to be sustainable in your own context and in your own environment.
Thank you.
Eric, do you want to comment too?
Yes, well, I think in addition to what Colleen said it's very important to be connected with the reality and the context where people are going to work. So it's very important to analyze first what is going on the ground. Now, according to the means that you have or the options that you discover here once that you are working in a certain environment and trying to support people, either through working together with the government, working with local organizations, also working with local organizations of people with disabilities or support groups. So you're going to choose then where are their strengths, and try to strengthen them. But on the other hand, also ensure that your actions remain sustainable. And that is a huge challenge. Now, more particularly when we talk about the thematic of aging, within humanity and inclusion, we have an approach where we look at different factors that discriminate let's say the access to services, or meaning that there are social determinants of individuals that make that sometimes they are excluded or not being brought to the right service at moments. Now, more particularly for humanity and inclusion, we choose a kind of three-way intersection, meaning age, disability, and gender. We have been seeing that these three factors, they interrelate very, very often when it comes to supporting with disabilities. And that's on how we're trying to build on services where we ensure that these three factors will not present any barrier for having access to services. So we adapt then the services and the solutions towards making sure that these three factors are not being discriminated. And disability, with disability, we feel that age and gender are two factors where people get excluded very often, if they are compounded.
So Eric, just on that note, I mean, you mentioned gender, and we know you're joining us from Afghanistan, and for many in the audience, they may not be aware of how discriminatory it is being a female, for instance, in that part of the world. Maybe I could just ask you to comment on that. What sort of initiatives are you doing specially to target women, and then maybe perhaps the elderly, if you can give a comment? Colleen, do you want to answer, please?
Sure. So some of the things that we have realized over the past 20 years is that it's not just good intentions, and we have to be actually very intentional about our efforts at being inclusive and considering persons considering gender issues in everything that we do, from the planning, from the execution, and for seniors as well. I think Eric can probably attest to from his experience in Afghanistan, elderly persons, female and disabled all together, are probably representing the most marginalized and the most at risk of just about any population out there. And so we have to be, I think, considering it in a very deliberate way, not just a passive way. And that's from all of our operations and our planning and the programs that we do.
Yes,
From a real practical sense as well, depending on where you are, it's working as well with the local governments, and Farah, you've probably got a lot of experience in that yourself, that you know, if you're working in a country and the country's own charter of rights and freedoms or their own policies and legal frameworks are not inclusive of persons with disabilities, of gender, and of women, then part of what we have to do is even working as an advocate around employing and ensuring and promoting the rights of these individuals as well. So not just from what we do from a medical and education, but as an advocate working with local governments and national governments as well.
Sure.
Yeah.
Thank you. Eric?
Yeah, just to come back to the solutions that we are looking at here in Afghanistan, we have a good example of our program to improve the physiotherapy education and education for prosthetic and orthotic technicians in Afghanistan, where, of course, the barrier of access for women, young women, to have access to that education was a huge issue here in Afghanistan. So we discussed then with the Ministry of Education, as well as with the families, yeah, of potential students, on what were their barriers, yeah, to say, okay, if they want to have their young daughter to go to school. So we looked at in how the local culture, you know, has to ensure that sometimes the young females are accompanied, yeah, then by a male family member. So we found solutions where, of course, also budget-wise, and the conditions in the school were proper, so that the young women could follow their 3-year education with a family member close by, etc. So, and this was a very good success, because our batches, you know, they presented over 70% of students that were female. So there was a huge interest, you know, to have then created that access to the education. And still, actually, and despite with the change of the government, that is not that we cannot really say that it's very friendly toward gender issues, while we can still continue this activity, because it has taken roots somewhere, yeah. And that whoever, you know, is at the government level here, people become then very practical, because they have also young women in their family that need care. They have also an issue of access of their own family members that need care. And if the female staff is not available, then that care will not be possible. So let's say these are solutions that have taken ground and taken root here in Afghanistan as well, and that we will still continue to go for.
And that is so very important, isn't it? As you highlighted, the education and inclusion of women in particular in most of the developing countries, or developing world rather, and that's so important. I'll move on to Pascal.
Yes.
Yeah, seven people in the world is regarded as having some form of disability. And do you think needs of disabled persons, especially elderly, are met?
So do you think the needs of disabled people are met,
Yeah.
in your opinion, with your organization, do you think?
I would say not just thinking globally, you know, where we can learn some information from, you know, the global burden of disease study. That's a very large international ongoing study that looks at causes and factors of impacts on morbidity and mortality, and that's worldwide. And we know that chronic diseases, and in fact, you know, neurologic conditions, including stroke, for instance, are some of the world's major contributors to loss of healthy living years. And so from 1990 to now, there's been a big switch from communicable diseases and childhood diseases and maternal health conditions being the major causes of morbidity and mortality. And now it's those secondary chronic conditions which affect people who are older for the most part. and it's a contribution to that global burden of disease and those elevated disability adjusted life years. And we see that strongest impact still in countries that are lower resourced. So, you know, your sub-equatorial Africa and in some of the Southern Asian countries as well. So I think no, the answer is no. The needs of elderly persons with disability are not met. And I think we're only just starting to appreciate the impact of disability on this aging population. As people live longer, we have a higher incidence of disability now, and we have a lot of work to do globally.
Yeah.
Eric, can you hear us?
Yes, I can hear you.
Yes, did you want to comment?
Yes, well, I think in addition to what Pauline said is that the experiences with humanity and inclusion, where we are working mainly in conflict settings, yeah, or in very difficult social situations, we know that globally, well, there are statistics that say that 40 million people are living in displacement, and if you then take a proportion of people that have a certain age or are advanced age, we know that they are not prioritized at all, and their needs are very unmet. So a solution has to be, of course, you know, to develop that specific expertise to improve their lives and to improve their function so that they can participate better. But you need also a whole basket of other services around them, such as psychosocial services, such as protection. Yeah. We know that age is also a factor where protection is affected in these situations, because the elderly are not anymore in their normal environment, and they lose all their resilient capacities that they would have when they were in their safe communities. But when they then are extracted from these communities, we see a whole range of unmet needs, and that even the best services available, or the assistance, the international assistance, is not paying attention to, because they have maybe focuses on other issues, or they would assume that if you are elderly or you live in a certain culture, that they will be taken care of by their families. But the reality is much different. There is a huge burden that is then created because of that situation of the elderly that needs to be taken care of. And some families then they choose priorities. Yeah, and unfortunately, the priority will not be on the specific needs of the person that is aging. This is what we see in the humanitarian space, unfortunately.
No, that's really good. I mean, both of you have emphasized that, you know, there are many, many discriminatory factors. There are cultural issues, the language barriers, there's the gender issues, as you've said, then of course the geopolitical situation, all the issues we've highlighted. I guess for our audience, do you think that you could give an example of how you would engage a family with a disability in an area like Afghanistan? I'm only putting you on the spot, Eric, because you're probably one of the few people who know what it's like over there.
Yeah, well, as I said, let's say the solutions that are offered is more like a basket of different services. Yeah, when we have an approach towards disability as such, it is always accompanied by psychosocial approaches as well, in terms of communication, in terms of understanding the dynamics within a family, and to look at the strengths and the weaknesses and how to address these weaknesses, so that, let's say, the person with that is aging will have a certain caring environment around him, yeah, or a reassuring environment around him. So this is more how we look at it, comparing to maybe a more individual or a vertical approach that probably would have a direct effect, yeah, if you provide care, if you provide the direct service. But once that you go out of the area, well, that person will not have enough capacity to sustain it by itself. So you need to create a caring environment around that person, with inclusive approaches around, as I said, psychosocial issues, look at protection issues, look at also the basic needs, yeah, that are maybe a bit different, yeah, from elderly people than from other members in the family. So I would go for that approach, yeah, and this is what we have seen to strengthen the community and the environment around the aging person, yeah, so that it is all the care and the support is becoming then more sustainable as well, and we need to strengthen these mechanisms that exist already, in a culture of taking care of somebody who is aging, but it needs to.
And where do you think, Eric, does the economics fit in? Because even though with the best psychosocial and other supports, it's the economics, isn't it, in countries like Afghanistan, for example?
It is the economics and what we see in our support in terms of livelihood programs, where, let's say, 10 or 15 years ago, let's say the average age of people participating still in economic activity is increasing. We see people that are getting older and are still being active economically speaking, because sometimes they have no choice. Or, as Colleen said, let's say that maybe their health is still sufficient, is sustained, and they can still be active and play a role in their families. And that's where the economics are going to speak, to be economically active, to have a good quality of life, and to sustain your health longer than before, than it was the case. That can be also a solution in terms of, looking at that economic solution, that you put forward.
Thank you, Colleen.
I mean, Eric described things extremely well. I think just maybe reflecting back on something Eric said before, and it's looking in the context of where you are and what the resources that you have. And maybe I can just describe a program that was in Haiti that I thought was just brilliant, that ultimately didn't require a lot of added resource and was a very local solution, where elderly women who were generally healthy but also economically not in a very good position at all. Often they didn't have family and were not necessarily able to work out in the markets any longer. They had those women providing in a secure environment daytime babysitting essentially for young children, so that their young single moms could go into the market and actually work, whereas they couldn't afford childcare services or take the children with them. So it was a win-win-win across multiple levels, with a very local women taking care of women. So seniors providing those single moms with that structure and education and history to be able to become better mothers. The children were getting appropriate care, and the moms were able to pursue vocation and work all at the same time. And you had this very nice environment which supported all three of those generations, which was a very nice example, I think, of local community solutions, keeping people living well and living in place. And that's been a bit of our tagline when it comes to healthy seniors and seniors living, is like helping seniors live well in place. So aging well at home and trying to promote that healthy living so that we try to avoid the impacts of disability longer term.
Yes, indeed. I mean, that's so very, that's an excellent initiative, and exactly what you need to engage the locals to support, systems within their own setup and structure and culturally appropriate, so forth. I've just been told we have very little time, so I'll let Pascal ask the next question. Pascal?
Yeah, I couldn't agree more what you have highlighted. I think so that brings the integral role of rehabilitation in this context. In specifically, what do you think the rehabilitation professionals need to know? Do you have any further comments?
I believe, well, that, let's say, the range of technology and techniques that the ISPRM is developing and also supporting worldwide is already a very good, is a very strong point. As I said, it needs to be accompanied with all the other services, and then more particularly the psychosocial approach. That is very important, because we feel that in the reality, when we look at all the global needs of a person with disability, of course, there is, of course, a rehab service that is important, but you need also that psychosocial dimension, that accompanies the person in improving his mental health as well, because I think in a lot of cases their mental health is also affected. So we need to see on how these two issues can be combined at one side, and then more particularly then in my case for the humanitarian space is to look at how the issues can be detected in terms of protection, because that is a huge issue as well, and not only the direct protection but future protection, on how policies can also make sure that people get still well accompanied in their desires and in their quality of life in the future, and not being abused in these specific humanitarian settings, and that the policies that these institutions are developing for people with who are aging and people with disability should be as inclusive as possible, yeah, and make the services adapted and accessible as possible for people with disabilities, including people that are aging.
Colleen?
Well, Eric said it fantastically, and I would just, with a final comment, is that as rehabilitation professionals, we're already used to working with a holistic approach to an individual and considering that whole biopsychosocial approach. And so I think as rehab professionals, we are very well positioned to work globally towards mitigation of those negative factors.
Excellent. Thank you, Colleen. So really, just to wrap it up, firstly, the comments, Eric, Colleen, you've made are phenomenal, and really help us understand what issues you're facing on the ground and in your various organizations from your perspective, your organizational directive as well, and how, I guess for us, what's really important is that as being part of the ISPRM and being an NGO, with mainly medical professionals, rehabilitation physicians, we are keen to support our partner INGOs and NGOs, and there's a lot of interest amongst our members to be useful in some context as appropriate, and that the DRC, the Disaster Rehabilitation Committee, works in disasters mainly, but many situations are disasters, but not because there's been a catastrophe. It's man-made usually, so it's combined natural and man-made disasters, unfortunately. But the aging of population, the rise of disabled persons surviving longer, requiring more need over time, and how we can set up appropriate interventions and look at models of care delivery. And already Eric mentioned, having mobile units going to those places rather than having hospital-like structures, because many countries don't have those sort of setups. We were just very fortunate where we work. And I guess, it's important to consider all of those factors and think about how we can work better together in the future and be more supportive. And I think that I speak for many of my colleagues in the ISPRM and the DRC. We are very grateful for people like yourselves and your organizations, because you make the world a better place for all of us. So thank you so very much. One from Afghanistan, where it's nearly midnight, and poor Colleen, who's on the side of the road in Canada. Thank you very much.
Thank you.
Thank you very much. Thank you so much. Bye-bye.
Bye.
Okay. Nacho, despides. Okay. Thank you very much, my dear friends. Well, we have now time for any questions for the audience, or I have some questions for you. Okay. I have one question. What are some of the challenges faced by the people with disabilities in an emergency situations? Could you please answer, please?
Eric, you're closer to that than I am right now.
Yeah, right. Well, I think the first challenge is to identify what are their priority needs, and then more particularly for the persons aging, is that, as I said, sometimes there are other priorities where it is assumed that a person with aging will not have these needs. And a good example in terms of assessment that we do in humanitarian settings and collecting information is using the questionnaire of the Washington Group, that can give a very quick view on where these functional needs are lying and which type of impairments or disabilities do appear specifically for people with aging, because of course they will not only be physical but sometimes also sensorial and communicative. So I believe that that is a good approach to have good assessment tools to start with, and to pinpoint and to identify what are these priority needs. And from there, of course, is to work then with the different capacities in terms of physical rehabilitation on how to address them and to prioritize them.
Yeah. And I think one important thing too is on a smaller level, on a person-to-person level, is to ensure for all of us that our patients with disability who are older, not just older, but anyone has a preparation plan in case of disasters, and has their emergency kit and has their own emergency plan, so that in the event of something that they are already prepared.
Okay, excellent. Dr. Devesa, do you have any question about this topic? Open your mic. No, Alessandro, do you have any questions?
Yes, I have a question for the speakers. I would like to ask them how the ICF might be useful for persons with disability, and the role of ISCF in the quality of life of them, and of course in the clinical practice, in the medical clinical practice. I think that it might be very useful to improve the knowledge about disability. What do you think about?
Certainly, I mean, using the ICF it helps us all speak the same language internationally, so that when we're able to collect data and analyze data, like specifically in the context of a disaster, for instance, using accessible tools with standardized ways of evaluating and classifying things allows us then to evaluate the outcomes and how the response worked and what the longer term impacts are, and able to share that knowledge on a more global basis, so that we're all talking the same language. Lack of data has been one of the major inhibitors of research in the area of disaster and humanitarian response. And so the ICF tool, used in the right context, can actually help with that.
Okay. Okay, Dr. Devesa, ready for your question? Open your mic to the right side in the chat.
You should switch on the mic.
Yes. Oh, okay. Do you have another question, Alejandro?
I have no questions for them. I think that Dr. Ignacio has some problem with his audio, and so
Yes.
if we could go on with the next session. Okay.
Okay.
Thank you, all speakers.
Yes.
Thanks.
Good evening. Yeah. Good day. Yeah. Bye.
Good evening.
Bye-bye.
Good evening for you, dear Fari. It's nice to see you and to hear you, even though you are far away.
Bye.
Thank you.
Okay.
And so, moving on to the next session today, an interview with the International Society for Prosthetics and Orthotics. Our speakers are Professor Carolina Schiappacasse and Professor Raji Hanspal. Both of them are past presidents of the International Society of Prosthetics and Orthotics, and will talk more about ISPO and its activity of improving the quality of life for persons with disabilities. Please, Professor Schiappacasse and Professor Hanspal.
Excuse me, one comment. I just listened to that Carolina Schiappacasse is not able to participate. Instead, will be Francesca Gimigliano, our vice president. So, sorry, Francesca, and sorry, Carolina. Go ahead, please.
Hey, welcome to the ISPRM Rehabilitation Week. Today, I will be interviewing Professor Rajiv Pal. Professor Rajiv Hanspal is a retired consultant in rehabilitation medicine. He's been the past president of the British Society for Rehabilitation, founder of the Amputee Medical Rehabilitation Society and the Special Interest Group for Electronic Assistive Equipment. He also developed the annual course for amputees and prosthetic rehabilitation and has published many national and internationally. And he's past president of ISPO, and in the name of ISPO, we will be interviewing him today. Hi, Rajiv, how are you?
Hello, Caroline. It's lovely to see you after such a long time. And I'm
Exactly,
sure this is
same
all
here.
because of the pandemic year, but it's always nice to see you. And thank you also for your introduction.
Okay, thank you. Same here. We hope we all meet again soon. I'll be asking you a couple of questions and then we can have the audience doing questions and answers also. First thing I would like you to explain to everybody else is what is ISPO, the International Society for Prosthetic Orthotics. Can you let us know?
Yes, certainly. And Caroline, as you know, ISPO stands for International Society for Prosthetics and Orthotics. I'd like to make a point. It is not for prosthetists and orthotists, but for prosthetics, the subject and the specialty itself. And I mustn't forget, Caroline, that you are actually one of the past vice presidents of this organization, well before I got onto the board. And that's why it's particularly nice to see you here in the interview. You've also been involved in ISPRM. Well, the society ISPO started just about 50 years ago. Some of you may know that we are celebrating our 50th anniversary and even last year published a new charter. It's a multidisciplinary society, and I think that's the crucial part here because the subject itself is a multidisciplinary service. The society may have started with 2 or 3 surgeons with an interest. If you look at the original board, they were either orthopedic surgeons or engineers working in prosthetics who believed in multidisciplinary work. In a way, ISPO, which is global and has members in over 100 countries and 70 national member societies, works a bit like a federation. Each of these countries have their own society, and then we have the international organization bringing all of them together. The aim, of course, has always been to provide a platform for effective exchange and communication on all aspects of the science and practice of prosthetics and orthotics care, associated engineering, and assistive technology. That's how the society stands. It's still very active. We've just published our golden anniversary charter available on the website and remains extremely active. I believe it is the first go-to organization for anything globally related to prosthetics and orthotics. So even the ISPRM members can access, and I'd like to believe it's the first organization they would go to. It's a subject I can go on for, but I think it'll take the whole 20 minutes. So I'm going to stop here.
Okay, thank you for letting us understand a bit more of ISPO. And I really believe many of ISPRM doctors are part of ISPO or should be. I will ask you now, how is ISPO involved in promoting healthy aging? Because the WHO has decided this is a year of aging, and we wanted to take this as a subject.
Well, yes. Main bulk of work ISPO does in prosthetics, the orthotics, mobility aids, wheelchairs, etc., relates to mobility. And we know that mobility and activity in all forms promotes good health, especially in the elderly, and that it actually even goes for sensory impairment. And sensory aids will assist and delay poor health. So it helps. If ISPO thus considers promoting good health, it is really by facilitating this extra mobility with the help of prostheses, orthoses, wheelchairs, and various other aids to help mobility, thus enhance good healthcare, especially since 80% of our population 80% of our population are elderly users. That's the way I would like to approach the belief of how we help the elderly.
Thank you. And related to that is we would like to know about the need for better access to assistive technology for the aging population. What about accessibility of that?
Well, I think it is a pity that only about 5 to 15% of the people in the world who need assistive technology have access to assistive technology. It's as little as that. And figures from the WHO point out that by the year 2040, 2050, there will be 2 billion people in the world who would need assistive technology. This highlights the need, absolutely essential, if we are to improve the health, mobility, participation, and all-round activity of the elderly.
Thank you very much. And just to finish, we want to let people know how they can get involved in ISPO activities.
Well, I think I'll start by saying, considering this is an ISPRM occasion, that ISPRM is collaborating with ISPO on many fronts anyway. And as an individual, a person can either join the ISPRM. There's certainly every activity, be it educational, training, liaison with others, is open even to non-members, though of course there may be slightly different rates. I call the activities as products. And if ISPO, that I believe does have very good products for this field, if somebody who's an ISPRM member needs them or feels they need them, they have access to it in any form, or even through their local or the national member society. We have conferences, we have set standards. For example, in Cape Town, we launched the WHO standards that the ISPO Society created, funded by USAID, of course, and that was launched, and that's for global use. They can access that, use it to see what their own country service is like, and which in a way also brings me to the most recent project that we had, and especially as I know it's going to be launched this Thursday, but the paper on it was published as a guest editorial written by Friedbert Kohler, who you all know. He's quite active, I believe, in ISPRM, and that was on LEAD, L-E-A-D, and Compass. Now, this is a massive project published. LEAD stands for Lower Extremity Absence Dataset, and Compass stands for Consensus Outcome Measures for Prosthetic Amputation Service. Now, these are available, and even as clinicians, you'll be able to use them all for the patients. So there are different aspects in which ISPRM could certainly be involved, individuals or as a main organization.
Yeah, I was actually representing ISPRM in the Lead and Compass
yes.
project.
So you know,
so, yeah, I know,
you know
very well.
Yes.
And yes. Okay, thank you very much for that. I really hope ISPRM and ISPO go on supporting each other and working and taking advantage of their different activities and making a more inclusive and accessible world for all the people with disabilities. I would really like to thank you very much for the time you gave us for this interview. I could keep on talking about many of things for ages, but time is a tyrant, you know.
I know.
So we'll go now to questions and answers session. Thank you very much, Rajiv. It's been a pleasure talking to you.
Thank you very much indeed, and may the association and collaboration between ISPO and ISPRM continue.
Okay, same. Bye-bye. Thank you.
Goodbye.
Bye-bye. Thank you.
Goodbye.
Thank you for this interesting interview. And now I have a question to Professor Anspal by Dr. Min Cheol Chang. What is a recent most focusing topic or theme of the ISPO?
Thank you very much for inviting me to this session. You heard the interview, and I believe the first question relates to what is the most current theme. I think if you use the word theme, it remains like our mission statement, which is to improve the quality of life for persons who may benefit from rehabilitation using prosthesis, orthosis, other mobility aids, and assistive technology, as I said earlier, to improve the mobility and all forms of activity which itself promotes good health. If I interpret the term theme as our latest product, our latest project, it remains providing a minimum data set and also the outcome measures for which there have been massive amount of debate internationally. US aid provided the funding, but in conjunction with WHO, ISPO formed a huge multidisciplinary group internationally, covering all aspects of the world, and used and created a set of evidence-based data set that could be required so that we speak a common language, and the same goes for outcome measures. This has been published in last month's as an editorial in last month's POI International, that's the journal of the ISPO, and is actually being launched globally this week, online, of course, webinar based from our head office in Brussels. That will be available for all people and can be used internationally. I think the word is used also over here about developing countries, and the need for prosthetic, orthotic, and assistive technology varies massively around the world. It is totally different in Europe compared to Far East or Africa, or the Americas, North and South. And it is with that in mind that ISPO is trying to improve the communication, which is largely going to be regionally based. If I go back to it's a project that goes almost not just 1 or 2 or 3 years or current right now, but over the decade more or less. In Cape Town, we formed, I say Cape Town because in 2017 our World Congress was in Cape Town. We formed and launched the ISPO FATO Council. FATO is the organization for P&O and assistive technology in the African continent, largely French-speaking based. But now ISPO and FATO work together because that's how ISPO will know more about the local needs and the local circumstances in that continent. 2 years later, in 2019, our World Congress was in Kobe, and that is when we launched a similar association with the organization that existed in Southeast Asia and the Pacific areas, and that council now helps improve and us to understand and assist the service product in that part of the world. The next World Congress was meant to be in Mexico, which unfortunately ended up being web-based, but that was the opportunity to improve the relationship and understanding so that more of the parts of the Latin American countries with the Fronteras Alliance would assist. So it's a question of spreading the network globally, and it's particularly important in prosthetics because the technology and the availability and the circumstances are quite different. This is also the reason why when we assisted WHO and we created the international standards, again, a project funded by USAID, prepared by ISPO with for WHO and is launched. This was launched 3 years ago. The standards have been set in such a way, there are 70 of them, that they could apply to every country in the world, no matter how advanced or developing or the local needs may be. And that is the recognition, that is why we need to work globally, but being aware of the regional circumstances. Also to highlight, unfortunately, though the name is ISPO, Prosthetics and Orthotics, it's actually assistive technology, and we mustn't forget wheelchairs, which is also within our remit. Many of you would know Claude Tardif, who worked for ICRC, who was the head of ICRC Rehab. He's our president as from this month. And the next person is also somebody you would all know, are likely to know, is David Constantine, who was the founder of Motability. So it's a very wide role through 70 national member societies. I think I've given a broad picture and answer to what's current and how it fits in with our midterm plan. I think
Thank you, Dr. Hanspal. Thank you for your question. And I think that you have also answered to the other question from Professor Ignacio. I would like to... Thank you.
I saw that written there, so I incorporated the answer.
Thank you so much. Thank you so much. I would like just to ask Professor Gimigliano some words. Professor Francesca Gimigliano from University Vanvitelli of Naples, next president of ISPRM. Please, Francesca.
I would like to take the occasion to thank once again Dr. Rajiv Hanspal for being here. We really appreciate the collaboration that is going on, has been going on for longer between ISPRM and ISPO. And I really value that we do some projects together. So I hope that this collaboration will continue in the future as well.
Thank you. Which is the question part in that is thank you for your good comments.
Thank you.
Perfect. Another questions. I have another question. Do you think that the professionals in prosthetics and orthotics are sufficient, are prepared sufficient for the necessities of developing countries?
Well, that's a very good question. Thank you very much. And I think that is one of the differences across the world. I live and work in the UK, and for us, main center would have a rehab physician. They would have a highly qualified prosthetist with his team, orthotist with his team, an engineer with their team, a physiotherapist, an occupational therapist, a psychologist, and a counselor. And it is pretty difficult for everywhere to have that. Even in my country, there are smaller centers which wouldn't have that. And that's where you need to have a referral system or a network of people coming from various places. If we look at just as an example, if we look at prescription rights itself, in some countries like in Netherlands, the doctor, the physician, is the main lead, and it's reflected quite well in our ISPO membership itself, where the majority of the members in the Netherlands, in the Dutch society, are doctors. If you then look at South Africa, 95% of the members are prosthetists, and the doctor has less of a role, but just does the amputation and then passes the case on to the prosthetist, will only get referred back to the physician, or the surgeon rather, because if there's a problem. I don't think they have many, well, I know they don't have many rehab physicians at all in South Africa. So the service in these different countries have to be tailor-made, largely based and planned, largely based on the need and the availability of that particular country, which is why we've gone down the route starting from 2017 of building alliances, collaboration with local networks. FATO in 2017, the Pacific East Asian countries, and then the ones in frontiers. In between, actually, also in Jordan, we formed a society. Now, this is as far as human resource is concerned. I think we mustn't forget when we talk about the different places, even the technology, because always going back even 20, 30 years, ISPOs made a point that the best prosthesis is, of course, obviously it's got to be the one that's going to be mostly used. The best prosthesis is often made using local resources. So if, for example, in India, where you have a good industry for tin and aluminium or the foot, they use those products to make the basic legs. You don't expect very high-tech, well, you do in a way, but not for the average whole nation complete supply, say microprocessor products. Having said that, of course, the countries are such that a company manufacturer told me that the highest sales of microprocessors they had was in India. But that's just the nature of a country that's got a massive population. Local products for the technology is best. The team must be based on the resource available there. To top it all, even a country like UK and America now has a shortage of prosthetists, qualified and trained prosthetists. And so these countries are thinking in terms of what we call cross-skilling. The physiotherapist learns some of the basic prosthetic aspects, works under supervision, and has a referral pattern to the prosthetist when it's required. So these are the three broad things: the technology, the human resource, and cross-skilling would be the main thrust of the answers I would give now.
Thank you very much. We now kindly ask you to remain connected a few minutes to reply our quick polls about your experience today.
Sorry, is a question for me, is it?
No. Thank you very much. I appreciate your answer.
Thank you, Professor.
Yes.
I think Juan Manuel has his hand up. He wants to ask something.
If you have any question for us, or we can conclude. Okay, I think that we can conclude. Thank you for joining us today. We look forward to see you tomorrow. And please remember to share on the social media the ISPRM Rehab Week and check out the program available for tomorrow. See you tomorrow. Bye, and thanks, ISPRM.
Thank you very much indeed. Thank you.
Bye.
Bye-bye.